Good morning, everybody. It is 9:30 or 31 on my computer, um, Thursday morning, and I keep thinking I'm going to be able to wear my short sleeve shirts, but 49 degrees this morning, so I'm still in long sleeves. What we're going to talk about today is testosterone therapy in women. Should you or shouldn't you? Yes or no? Well, depends on who you look at and who you read. So I've talked about testosterone therapy in men. I've written several articles on testosterone replacement therapy in men. Good morning, Linda. And so I was asked to review testosterone therapy for women. And when I was in practice, I did that for 30 years. And as a health coach, I collaborate with doctors, and we do testosterone therapy for women that meet the criteria. So again, I've never treated just numbers. You actually treat the person. So you have to figure out, is this a viable option? Because testosterone replacement therapy in women is not FDA approved. The caveat to that is there was a product that I used way back in 1986 called Estratest, and that was a mixture of estradiol and testosterone, methyl testosterone 1 milligram, that was FDA approved for hormone replacement therapy in postmenopausal women. So the FDA says that testosterone therapy in women is off-label, despite the fact that Estratest was an FDA-approved hormone replacement therapy for women going way back. I'm not sure it's still on the market, but it worked well. So if we did testosterone levels on women and they met the criteria for symptomatic low testosterone symptoms, Estratest worked pretty well. And then I looked at a review article from 2017, a meta-analysis, and actually it's called a global consensus position statement on the use of testosterone therapy in women. And they basically put the kibosh on testosterone therapy for women from a group of global experts. And the only indication that they felt in which testosterone replacement in women was helpful was female sexual arousal disorder and hypoactive sexual desire or something like that. So basically decreased sex drive, low sex drive. There's a whole list of criteria for FSAD, and they recommend psychologic testing in order to make that diagnosis. Well, there is a pharmaceutical medication that is FDA approved for treatment of female sexual arousal disorder and hypoactive sexual response in women. I cannot remember the name of it because I reviewed it and discharged it in my mind immediately and actually wrote an article about it. It only works, I'm going to say, if I remember right, 50% of the time for improving sexual response, etc. in women. And it improves sexual activity or episodes of sexual activity by 1 time per month. And this global consensus basically talks about that. That even testosterone therapy is only effective to increase sexual episodes, I guess we should say, by 1 time per month. Well, that's not been my experience over the last, what would this be, 35 years. And so when I really kind of dove headlong into menopausal hormone replacement therapy for women in 1992, that's what I got to be known for through my whole career. Testosterone was a mainstay if there were symptoms, and the most common symptom is decreased libido, sex drive. The psychologic testing involves sexual fantasy, sexual thoughts, response to sexual activity. And I've talked about the Adams score for men. That's the Androgen Deficiency in Aging Male scoring system from St. Louis University, my alma mater. A series of 10 questions. I basically took that Adam questionnaire and gave it to women and eliminated the question about erectile dysfunction or less firm erections and replaced it with decreased clitoral sensitivity or loss of orgasmic capability. In other words, they didn't feel what they used to feel. And sure enough, if you take that Adams score, and there's no studies to support this, it was just my little thing. I still use it. Men and women have very similar low T symptoms. And so for women, they don't have penises, so they don't get erectile dysfunction. But embryologically, the clitoris and the penis are, men and women embryologically are the same until about 6 weeks as an embryo, when testosterone for boys suppresses the embryologic structures that lead to female external genitalia. But the penis and the clitoris are basically analogous. So you don't get erectile dysfunction of the clitoris, but you do get decreased sensitivity. And the clitoris is quite a bit bigger than everybody thinks it is. It's not that just little part that you can see. It actually goes down around the vagina and the labia, and almost, not quite, but almost encircles them. We know that from doing the O shot, when we put platelet-rich plasma in the clitoris for improved sexual function of the clitoris, as well as improved control of bladder symptoms like leakage, stress incontinence, etc. So the O shot really kind of delineated the fact that the clitoris is more than just the little part that you can see. It actually encircles the entrance to the vagina. So then I looked at, this is called the Global Consensus Position Statement on the Use of Testosterone Replacement in Women, and looked at all the experts. And of course they have to claim, or they have to state, if disclosure, if they're affiliated with any particular company, group, or if they're paid. About 90%, I didn't do the actual math, but about 90% of the people on this global consensus were paid consultants or had a financial relationship with a pharmaceutical company. And one of their statements was, you can use male preparation testosterone therapy in women who have hypoactive sexual disorder, female arousal sexual disorder, and I'm not using the correct name for hypoactive, but it's basically decreased sex drive. So they're saying decreased sex drive is an indication for physiologic replacement of testosterone in only menopausal women. They claim that there is no effect statistically in premenopausal women. Well, I got news for you. Most of the studies that have been done are on women that are transitioning to males. Okay, so sexual reassignment. And so those studies, that's become a more and more common thing. I took care of quite a few of those women that were transitioning to males. I've taken care of a lot of men transitioning to females. But a lot of the research on testosterone in premenopausal women or perimenopausal women are in transsexuals. So there is research out there. If you only look at research on women that remain women, there's not a whole lot out there. So most of this that I'm telling you is clinical acumen, which is the art of medicine. So if you replace something that is falling naturally, they keep saying normally, and that indicates to me that even though menopause is a normal transition, the symptoms of menopause can be reversed. And part of that is testosterone replacement. So let's go through the benefits. I put a graphic up showing reduction in overall mortality in aging men that were on testosterone therapy. And they were looking at non-fatal stroke, non-fatal heart attack, and then mortality, death rates. And the death rate plummets on men that are on testosterone replacement. So the question is, does that transition to women as well? And once again, most of the research has been done on transsexual female to male. So it's typically marketed to men. Testosterone replacement is marketed to men. You have seen testosterone pellet companies, BioTE for instance, that market testosterone replacement pellets to women, but women also produce testosterone. Okay, so that's part of my physiology class, is to teach my students the role and where it comes from of testosterone in women. So women produce smaller amounts than men, quite a bit smaller amounts for men. And if it dips below normal for women, and there's the problem. How do you decide what's abnormal for women? So drops in testosterone for women can negatively impact their health just like they do men. So testosterone replacement therapy may be indicated for treatment of low testosterone in women to improve overall health outcomes, but more importantly to improve their daily lives. So virtually, not all, but virtually all, I'm going to say 98% of the women that I've been involved with treating with testosterone replacement have had a positive impact. And these are the potential health benefits that we're going to talk about in this class. So testosterone does a lot for you. The pituitary gland controls how much testosterone is produced in the body, and it can signal to the body that it has enough or too much testosterone. That's a negative feedback mechanism in physiology. So it can over or under produce the hormone, and that is hormone imbalance, which you've heard me preach and preach and preach about hormone balance. It's the second part of my shining protocol, the first being sleep, second is hormone balance. And I'm not just talking about the sex hormones, I'm talking about all of them, or at least the ones that we can impact. So two main reasons that women have low testosterone. One is the normal, quote unquote, aging process. So like men, women's testosterone levels diminish naturally, which I prefer that term rather than normally, with age, and particularly after menopause. So testosterone is still produced in the ovary, even after menopause, even though estradiol and progesterone do not. They're not produced. And there was a gynecologist named John Rock. I can't remember where he was. He would never take ovaries out during hysterectomy in a woman prior to the age of about 55 because they continued to produce some testosterone. He thought that was just a horrifying idea. And so if you basically, if you take a woman's ovaries out at 35, there's a whole lot of stuff that goes away that's problematic. And the idea is to save that woman from developing ovarian cancer in the future, which is about 1 in 20 women, higher if, the only time I took ovaries out, just because women asked me to, is if their mother or their daughter, so a first degree relative, had ovarian cancer. And that research comes from the Gilda Radner Society. She died of ovarian cancer at age 41. And Gene Wilder, her husband, basically poured a lot of money into research on how to prevent ovarian cancer in women. Okay, the other reason, so I'm tangential, I'm being ADHD, sorry. The other reason why women may have low testosterone is issues with their pituitary glands or ovaries. So it's an integral role in the synthesis of testosterone. So your pituitary gland, commonly known as the master endocrine gland, although I still think that's the hypothalamus, it will signal the ovaries on how much testosterone to produce. Okay, this happens in men as well. So any issue with the pituitary gland or the ovaries can affect testosterone levels. Okay, so typical body functions can lead to natural reduction of hormones like estrogen and testosterone over time. And so when women approach menopause, commonly known as perimenopause, meaning they're not menopausal but they have menopausal symptoms. And that was a niche that I fulfilled for the 30 some years I was in practice, was treating perimenopausal women who were basically suffering from low hormone levels, even though they weren't technically biologically menopausal. But they had menopausal symptoms from low estrogen, testosterone, progesterone imbalance levels. And some women may experience significant reductions in testosterone when taking oral estrogen medications. Think birth control pills, which have a synthetic estrogen called, most of them have ethinyl estradiol in them. And I cannot tell you how many younger women in their 20s that I treated with testosterone injections because they had no sex drive. Birth control pills raise sex hormone binding globulin, so even though their total testosterone was normal, their bioavailable testosterone was significantly low, like couldn't be measured. And the global consensus people say that free testosterone levels don't mean anything. Well, that's actually not correct, because free testosterone is bioavailable. If it's bound to the sex hormone binding globulin, it can mean normal all day long and you're still going to have low testosterone symptoms. So ovarian dysfunction, what I always call, well, I mean, think about it. Ovarian dysfunction, the ovaries aren't functioning properly. That's pretty typical past the age of 38. That's why fertility rates fall significantly at age 35 to 40. That's ovarian dysfunction. And so that was part of my infertility practice all the years that I was doing infertility treatment. And then you can have ovarian failure. Women that have had in their teenage years that have horrifying cancers and have chemotherapy, or they get their pelvis radiated, they have ovarian failure. And they have low levels of testosterone. Thyroid disease can affect testosterone. Certain types of cancer can affect testosterone. So what does testosterone really do for a woman? So we've talked about what it does for men, although it's been a while. So even though they produce less testosterone than men, it is essential testosterone in the support of several body functions. So if you have normal, sustained female testosterone levels, that can help support the maintenance and healthy growth of bones. It increases and maintains muscle mass. It decreases the amount of fat storage. So men get the little punch from low testosterone, so do women, especially when they're postmenopausal. It can promote a sexual drive or a healthy libido, decreases the risk of vaginal atrophy. And there's some research to suggest that normal testosterone levels in women can even help support cardiovascular health. And we'll talk about normal levels because that's not quite that well defined here in a little bit. So testosterone is more than just a sex hormone. It's more than just a male hormone. It's a hormone, and it has functions. It's an integral part of hormone balance for overall good health and longevity. So I showed you the mortality rate for men on testosterone replacement therapy plunges. It's significantly lower. That's in that graphic. So too little testosterone can lead to a variety of health diseases like osteoporosis. So men get osteoporosis, just like women do. Obesity, that's a multifactorial thing, and that's what we've been talking about in class for about 6 weeks, the multifactorial and hormonal theory of obesity. It can decrease vaginal tone, lead to pelvic floor insufficiency or pelvic floor dysfunction, so muscular atrophy in the pelvis, depression, and anxiety for that matter. And then there's a higher risk of certain cancers with testosterone deficiency. And I shouldn't say deficiency, suboptimal testosterone levels. True for both men and women. So what are the symptoms in women? So there can be several. The first one that everybody thinks about is loss of sex drive. And the list I'm looking at, and that's the first thing that they addressed in the global consensus meta-analysis, But a lot of these lists that I look at have sexual desire and decreased libido near the last. And that's the first thing everybody thinks of. So what else? Muscle weakness. You get atrophy, you get sarcopenia, it's called, loss of muscle mass. Sluggishness or fatigue. How many of us have that? Lots. Hormone imbalance makes you fatigued. You're lethargic. That can also be vitamins and minerals and what you're eating, how much you weigh, if you have hypertension, if you're taking meds for chronic inflammatory illnesses or chronic disease. Sleep disturbances. 40% of Americans have sleep disturbances, and we've talked about the health effects of poor sleep. Weight gain, that has to do with that inflammatory fat in the lower abdomen that is so hard on the cardiovascular system. There can be issues with infertility. The global consensus people think that there's no indication for testosterone replacement for treatment of infertility, even though it is one of the symptoms of low testosterone in women. Okay, high testosterone, totally different story, and we'll talk about that as well. Loss of bone density or osteopenia, osteoporosis, vaginal dryness. It's not just estrogen. Estrogen and testosterone work together, just like estrogen and progesterone work together. Loss of libido, decreased sexual satisfaction, so difficulty achieving orgasm in a woman that has previously been multi-orgasmic, let's say. Okay, so since they present as many other issues, low testosterone levels in women frequently are undiagnosed. So they're always looking for these other weird things that, these other things that can cause all that, so that you can get a drug therapy, a pharmaceutical, FDA approved thing. So think Prozac for depression, when a lot of times all women need is hormone balance, and all their depression and anxiety pretty much goes away. Okay, so there's also emotional symptoms with low testosterone. Lack of motivation. I hear that from men all the time. I'm just not motivated to do anything. I want to lay around and do nothing. Well, that's true for women as well. They're just not motivated. I just talked to a woman last week who's a professional, and if she does not take she takes testosterone on a daily basis, and then is going to start a booster testosterone injection because her sex drive isn't where it wants to be. But at age 50, she's not as motivated in her professional capacity, and that's one of the questions. Decreased work performance on the ADAM questionnaire for men applies to women. Feelings of depression, that can also be vitamin D. There can be some serotonin problems as well, but what if you didn't have to take Zoloft or Celexa or some of the other serotonin reuptake inhibitors, which are only supposed to be used for about 3 months anyway, if all you have is a hormone imbalance as you get older. And I say over 40 is older. That's kind of nasty to say, because I'm 60 and I'm like 25. Difficulty concentrating, hear that all the time. And we'll do a class on human growth hormone releasing hormones as far as concentration and mental acuity, probably next week. That's an amazing thing to do. It's not cheap, but it makes a world of difference in your quality of life. And then problems with memory and cognition, that also has to do with hormone imbalance and suboptimal testosterone levels. And we'll talk about that with human growth hormone releasing hormone as well. So if those symptoms are familiar to you, even if you're younger, so when 20 to 35-year-old women on birth control pills, not all, but a lot have decreased sex drive. They have no libido, and that's testosterone being bound to sex hormone binding globulin. So talk to your doctor. You have to find a doctor that's into functional medicine and knows about hormones. If they don't know anything about hormones, they're going to say, nope, we're not doing hormones. Or reach out to me, I'll find you one that gets it. So a blood test can determine whether a woman has low testosterone. So and that's technically true. Remember, blood tests are on the Gaussian distribution curve, the bell curve. So by the time you get to the lower normal number, you were in the lowest 2.5 well, you're right above the 2.5 percentile for the entire population. And hormones need to be in the upper quartile, 75th to 95th percentile to be optimal for most people. So, so what's considered a low testosterone can depend on age, and of course they're going to give you a lower number as you get older, just like they do with DHEA-S levels that we talked about a couple of days ago, and then health, and then other issues. So you have to maintain several vital body functions: appearance, memory, cognition, and maintaining normal age-appropriate levels is essential for good health and positive quality of life. And I would argue that maintaining optimal levels for that particular person, that woman, that man, on testosterone or any other hormone that you're impacting, there's a sweet spot. Sorry, I took my meds. There's a sweet spot for each person, and the art of medicine and a hormone and functional medicine doctor is to find out where that sweet spot is, how to get you to the sweet spot, and then how to keep you there. So even women who experience low testosterone just from natural aging can find comfort and relief from testosterone replacement therapy. That's kind of how it works, right? Hey, Shelly, glad you're doing that. Okay, so the benefits. What's the benefits? You're taking testosterone. Why would you do that other than a better sex life or sex drive or sexual fantasy or sexual thoughts or orgasm capability? So what else? Maybe a healthier heart. There's just not a whole lot of research on women that aren't transitioning to men, but the research on women transitioning to men is there. So low testosterone raises your risk of cardiovascular disease, heart attack, stroke, and death. The exact opposite of what you heard. And then the ads about testosterone replacement therapy from lawyers looking for malpractice cases. Everything that they say on those ads about the potential side effects of testosterone are the symptoms and side effects of low testosterone. So, will TRT, testosterone replacement therapy, help with your risk of heart disease or stroke? True in men, maybe in women. More and more research. So you improve red blood cell production with testosterone, so you have to watch that. Although my current medical director thinks that having a high hematocrit, he can't find any evidence that it actually increases the risk of stroke. But that's what everybody thinks. If your hematocrit's too high, you raise your risk of blood clotting and stroke. Recent study, 83,000 men found men with low testosterone levels who returned to normal levels decreased their risk of heart attack by 24% and the risk of stroke by 36%. What we don't know is if that generalizes to women. So men and women are different, but kind of their hearts are not, and the effects of things that are going on in the body and the effects on the heart are not. Okay, decreased risk of obesity, potential health benefits of testosterone in women. So women have less natural muscle mass than men, and testosterone's linked to muscle mass. So a leaner body naturally helps with control of weight. It increases energy. It can decrease fat levels by promoting muscle mass and strength at the same time. We know that from men. I know that from talking to women and treating them since 1992 for testosterone. Strong bones. So testosterone is directly linked to bone density. So is estradiol, so is vitamin D, so is calcium. And low testosterone directly correlates with a risk of osteoporosis in both men and women. That's clinical trials. And TRT can help boost bone mineral density in the hip and spine. I talked about that 2 or 3 weeks ago, I think. And that was in men. Studies of females transitioning into males found that testosterone replacement therapy naturally improved bone density in those individuals. Okay, what about your cognition, your ability to think clearly? So, promising research in men showing that men with higher total testosterone, and again, I follow free and bioavailable testosterone more than total because of the effect of sex hormone binding globulin. But good optimal testosterone levels generally reduce the risk of Alzheimer's disease in men. So it's important to the ability to think. It improves verbal memory, processing speed, and spatial memory. Also true for human growth hormone releasing hormone. And I have several men and women that take both. They take their testosterone, their human growth hormone releasing hormone, and they're flitting around like young, energetic people. So that research on Alzheimer's predominantly in men. The human growth hormone releasing hormone research is in men and women. Of course, the most promising evidence for TRT in women relates to their sex drive. So an appropriate testosterone level for that person contributes to healthy sexual arousal and activity. Okay, and boosting low T in women is almost immediate. So they get energetic. They usually have a better sex drive within like 2 days. Men, and then they get all the benefits that we talk about. How long does it take? How long does it take for androgel to work in men? I did an article. Pardon me. I did an article on that 2-3 weeks ago. So that was all done on men. Women tend to get benefit from testosterone almost immediately. Okay, and then better mood. So people with low testosterone typically are fatigued, they're irritable, and they're depressed. Not always, but that's part of the symptom complex. So testosterone may improve mood, well-being, promote healthy energy levels, and then just having more energy can also boost your mood. Simple. Okay, what are the risks? So there's risks and benefits. So you discuss all those with your doctor, or you discuss them with me, and we'll go over that with the medical directors. People with blood clotting disorders like previous deep venous thrombosis, previous pulmonary embolism, little iffy. There's no real evidence, like I said, my medical director said there's no evidence of increased risk of blood clotting on testosterone, even with a high hematocrit. And I've searched and I haven't found it either. It's just generally assumed, kind of like it was assumed that testosterone causes prostate cancer in men. That's just been debunked. That's not true. That comes out of an article from 1941 on one guy that got prostate cancer on testosterone replacement. So testosterone replacement goes all the way back to 1939. It's more common in women the last 15 years probably. You do have an increased urinary output in some, in women, not men necessarily, and then some fluid retention. So lower extremity ankle edema. We always ask our men and women that are on testosterone, are you retaining water? Enlargement of the breast, specifically in men, but low testosterone causes enlargement of the breast, or moobs, man boobs, right? It can also cause, for men, gynecomastia, which is breast or nipple tenderness. Don't hear that from women because they're not taking as much testosterone. An increase in aggression. Well, that is true if you overtreat. And so I do agree with the global consensus people that you treat the physiologic levels. So what's a physiologic level? Well, from the human physiology textbook, that in women, that's 20 to 80 total testosterone, and then 2 to 8 free testosterone. Men, different story. But if your blood level of total testosterone is 20 and you're a woman and you have all the symptoms of testosterone or low testosterone, getting your level up to about 60 will make a huge difference. So 20 to 60. So 20 technically isn't low or deficient, but it's certainly suboptimal. And then more mood swings. You can have more mood swings with testosterone replacement. I do have, not very often, in this past year I've had one male, that took testosterone and got really irritable. But now he has low testosterone levels again. We tried to treat him with DHEA, and I don't think he's he's not converting enough. So the idea is to figure out, okay, at what testosterone level replacement level can he get without having that side effect? So really what you do is you discuss all this with a physician that understands hormones. There's several different ways you can take hormone replacement therapy. The global consensus people say transdermal androgel, basically, or Testim, or shots. They don't agree with compounding. Okay, so how do you compound? Which is virtually most of what I've done for the last 30 years, basically. So there's topical gels or creams that can be compounded, and what you're doing is individualizing the dosing for that particular person. Just like you're individually coming up with a protocol for that person and finding out what their sweet spot is, where they're not overtreated, but they're not undertreated, and all their symptoms go away. And low testosterone symptoms go away fast. So transdermal patches, hard to keep on. Injections, traditional, that goes back to 1939, especially in men. Oral formulations, especially methyl testosterone, can have an effect on lipids, meaning your HDL level, high density lipoprotein, cholesterol taxi will go down or can go down. No effect on low density lipoprotein. Cholesterol triglycerides may rise. So there is one medical director I work with who does not give oral testosterone to women. Oral testosterone doesn't work in men. Oral testosterone does not work in men. Oral testosterone in women, yes, it can be given as a vaginal preparation, cream or gel that's compounded and placed with a topic click pearl, it's called. Pretty easy to use. It's actually less expensive than almost every other method for women. So basically, you'll notice the effects within a few days, within a few weeks. Women have improved sexual drive, libido, sexual performance, sexual response, and mood, and more energetic almost immediately. The sex drive is usually pretty immediate as well in men and women. The energy within 48 hours. Okay, what are the myths of and I know this is a long class, but what are the myths? So the most common myths surrounding testosterone replacement for women. The myth, testosterone can cause breast cancer. So some people posit that there's a link to the development of breast cancer. No evidence. There is absolutely no evidence that testosterone raises the risk of breast cancer. The myth, testosterone masculinizes female. So for 65 years, medical journals have recognized that testosterone effect is dose dependent and that in lower doses for women, testosterone stimulates femininity. You can masculinize a female with testosterone if you're not monitoring her. Monitoring is the key. So we do labs on people on hormones and testosterone every 4 months. Next myth, testosterone replacement for men and women is the same. Well, men and women have different biologies and optimal levels for testosterone. So it's necessary to find the right formulation and dosage based on unique factors for that person and their medical history. Men and women require different optimal doses of testosterone, and every person has their own unique needs. So oversight by a physician is necessary. And testosterone is a Schedule 3 on the DEA. It's a controlled substance. So it's monitored. If it's correctly monitored, it's monitored more than a blood. I talked to a guy 6 months ago. He was on testosterone, and I asked him. He said it's not working. And I said, when's the last time your doctor did a blood test on you? And he says, 2 years ago. That's not how you do testosterone replacement therapy. That's how men get in trouble and have side effects and issues. So you have to monitor. Okay, and next myth, testosterone causes aggression. Well, that's true with anabolic steroids. So roid rage does not occur with testosterone therapy that's monitored. And so I've had two. So I talked to you about the guy last fall. He was irritable. He wasn't aggressive. There was a guy in Tulsa 4 or 5 years ago. he felt homicidal, so we had to adjust his dose. That's it. That's all I've ever heard. 2 years, probably 3,500 men that we've treated for testosterone replacement. And so, even large pharmacologic doses of intramuscular testosterone do not increase aggressive behavior if they're dosed appropriately and monitored. So there's a paper called The Beneficial Effects of Testosterone Therapy in Women Measured by the Validated Menopausal Rating Scale. And that scale shows in that study that testosterone decreases anxiety, irritability, and aggression in women if it's appropriately dosed and if it's appropriately monitored. So I was asked to do a class on testosterone replacement therapy in women. There it is. I talk about the levels. You have to, I can't give you an optimal level. It's for each person, man or woman, but we're talking about women. So figuring out the sweet spot is part of the deal. And then figuring out if a woman would actually benefit. You can't just give it because somebody has low testosterone levels. If they're not symptomatic, that's what their body wants. They're fine. So male hormones, they're called androgenic hormones, are not just for males. So DHEA is one, testosterone is one. In women, they're made in the adrenal gland and the ovary. In men, most testosterone is in the testicle. Women continue to make testosterone in their ovaries even though they're menopausal. People forget that. They're just not efficient, just like ovarian dysfunction prior to menopause. Same reason why women in their 40s don't ovulate and have as much fertility as well. So that's a little primer. It's 40 minutes of information on testosterone replacement therapy in women. If you need help, email me, messenger me. I'll find you a doctor that will work with you. Most of it is the history, what's going on, and then the blood test, and then correlating the two. So healthwithout.risk.com is how you can get me, or you can text me 636-891-5055. I'll send you a health history, and we'll talk about it, see if it's a good thing for you, or a potentially good thing for you. All of you on here, great to see you. Hope everybody has a great day. Hopefully we're going to have spring weather so I can wear short sleeves and show you all my cool short sleeve summer shirts coming up. And then tomorrow we're going to talk more about how to lose weight, what I think is the correct way, taking hormones into account. So have a great day. I will talk to you tomorrow, same time. See, assuming my 3-letter internet service provider is behaving. Okay, see ya. Bye.